Greetings everyone, I'm Dr. Tarun Prashant. Today's class is going to be on crystal deposition disorders. So what are the objectives or what is the overview of today's class? It's going to consist of three important terminologies. One, a disease called as gout. The other, calcium pyrophosphate crystal associated arthropathy, and also basic calcium phosphate crystal deposition disorder. So in all of this, one thing is common. There is one problem or a disorder which occurs due to deposition of crystals. So the other word which also comes under this whole or can be coined for all these three are crystal induced arthropathy. So if they are going to ask you about crystal induced arthropathy, it again coins down to these three things. One being gout, the other being CPPD, and the other being the basic calcium phosphate which gets deposited and the issues that it causes to us. So starting with gout. So what is gout? The definition of gout is it is a systemic inflammatory disorder which occurs due to crystal deposition disease caused due to the deposition of monosodium urate crystals in the joints and other tissues. But why does this occur? It initially occurs due to an increased uric acid level in our blood, which we also coin as hyperuricemia. So it is estimated that 1 to 2.5% of the adults in developed countries get affected due to it. So why do we get affected due to it? Or the initial part of how gout was first coined was as early as in the Latin era when they called it the word gutta, which means a drop, which was more due to the acute gout in which there is almost a drop of poison in the joint. And Hippocrates in the early 460 BC had clearly told that there is a rarity of gout in premenopausal women as well as in children. And Thomas Sydenham, himself a sufferer of this, had given a detailed clinical description of gout, identifying a number of distinguishing features that we still continue to recognize. So, when does gout come and how does it come? So, it comes due to two things. One, a primary, and two, a secondary. Primary what? A primary uricemia or a secondary uricemia in which you're going to see increased uric levels in the body. So, when does the uric acid level increase? It increases when there is an increase in the uptake or a decrease in the excretion of uric acid. The other being secondary gout, wherein in hereditary conditions or in acquired disorders such as myeloproliferative disorders or diuretic usage and in renal failure, there is increased amount of uric acid which gets settled in the body. It's important to know what causes primary as well as secondary uricemia. So, in primary uricemia, wherein there is no associated condition which causes the same, the uric acid under secretion, it is idiopathic, urate's production is more, and there is a deficiency of HGPRT and there is overactivity of the PRP, which is a breakdown product in order to form uric acid. So, it's also called phosphoribosyl pyrophosphate. Whereas in secondary hyperuricemia, it develops during the course of other diseases such as leukemias, in case of lymphomas, and while giving chemotherapy. Some drug therapies like the diuretics, the thiazide diuretics and furosemide, this occurs. It can also occur when they are having comorbidities like in case of diabetic ketoacidosis, hemolytic anemias and psoriasis. And it goes to another fold when the patient is going to have more of hypoxemia, or in conditions or in places where there's hypoxemia, there's obesity and there is hypoperfusion. So, gout is the most common inflammatory joint disease in men with peak onset in the 5th decade. So, the risk factors, 30 to 40% is contributed by the family. There is 50% increase in the patient when they are going to be alcoholics, when there is renal impairment, obesity. This triad of atherosclerosis, hyperlipidemia and hypertension adds on to the value of the risk factors, and any one of these risk factors, when they join together with this, lead on to the under excretion of urate crystals, and this can lead to hyperuricemia. There is also another subgroup of female patients who are going to be on diuretics, which will also lead on to the same. So, the onset of gout in men prior to adulthood or in women before menopause is rare and should raise the possibility of an inherited disorder or a secondary cause due for the hyperuricemia. And when does this occur? It occurs in two forms. The first form being a complete absence or the deficiency of hypoxanthine guanine phosphoribosyl transferase, and that is seen in Lesch-Nyhan syndrome. It's a X-linked disorder, whereas a partial deficiency of the same is seen in the Kelly-Siegmüller syndrome, and both of these lead to an increased state of hyperuricemia. So, coming to the pathophysiology, that it occurs due to hyperuricemia, which is the basis of gout. It might occur due to a dysfunctional nucleic acid metabolism, which leads to this, a deposition of monosodium urate crystals in the synovium joint, and these crystals cause an inflammatory response, causing the activation of proteases, prostaglandins and leukotrienes, which are all inflammatory mediators, which is going to send a response throughout the body that there is something going wrong in that particular joint.